Good afternoon, everyone, and welcome to the Black Health Trust Weekly Program. We're so pleased you've chosen to empower yourselves today by joining us. And to the mothers out there, let me wish you a very happy Mother's Day. It's great to have our regular attendees back and those new to our program. My name is Barbara Neighbor Stevens, and I will be serving as hostess and co-moderator today. I hope you are all doing well. Today, our discussion will center on exploring diseases that impact our community, hereditary amyloidosis cardiomyopathy, and inflammatory bowel disease. Our co-producer today is Mr. Arnie Joseph. I will co-moderate with Dr. Ivan Waltz, and together we will co-moderate with our founder and leader, Dr. Randall Maxey. Dr. Maxey is the Chief Medical Officer of Advanced Community Medical Care Corporation and founder of Black Health Trust. Black Health Trust was founded in response to the coronavirus global pandemic and Dr. Randall Maxey's personal desire to keep his own family safe, and fortunate for us, his commitment to informing his tribe evolved into a much larger vision. The purpose and mission of the Black Health Trust is to provide credible insights from our community health experts to best serve our communities of color with a coalition of leading and longstanding Black medical professionals across a diverse spectrum of disciplines to offer their expertise and insights into our physical and mental health during these challenging times. These opinions are offered to help educate and inspire you to take your health seriously and to ask questions of your own medical practitioners. We do have a few housekeeping items to dispense with. This video conference is a live program and is being recorded on different public platforms like Facebook Live and YouTube. Your participation on this program is completely voluntary. And if you choose to participate and prefer not to have your image and likeness displayed, there are visual and audio settings on your personal device you can use to block your picture and mute your voice. That said, all participants will be muted by our Zoom technician initially. We ask that you remain muted until the host or moderator asks you to contribute in order to minimize the distraction of background noise so that we can give 100% attention to our speakers. Check now, please, and make sure that your device is on mute until called on to speak, and then once again, place your device back on mute when you are done speaking. With regards to the chat room, if you have questions, you can enter them into the chat room. Please limit your questions to 2 questions per topic being addressed. And please do not use this forum to advertise or promote your products. Understand that there may not be sufficient time to get to all the questions during the call, but we will do our best. We do have a very important disclaimer that I will share with you now. Please note that the information communicated on this program is not intended or deemed to be medical or legal advice, and you should always consult your own medical or legal professional for advice and direction pertaining to your particular situation and needs. The information presented here is not advice, but rather opinions and recommendations from credible sources. Black Health Trust, its representatives, members, employees, attendees, heirs, assigns, and guest speakers and presenters assume no liability whatsoever in connection with the information presented or used by anyone, nor are these discussions directed to specific situations. Again, we strongly encourage all attendees of the program to consult their own legal or medical professional for conclusive guidance on how to proceed in your own personal circumstances. We are in this together. If this program has been valuable and interesting to you, please visit the website to learn more about our programming and how you can support Black Health Trust so that we can continue bringing our community outstanding content. The website is blackhealthtrust.org. If you send an email to social@blackhealthtrust.org, please include your first and last name so that you may be added to the Black Health Trust mailing list. If you don't want to be included in the mailing list, please just indicate that in your email. We want to thank the Black Health Trust Steering Committee, the Executive Board, its virtual administrative assistant, our media production and Zoom technician, our Black Health Trust supporters, and all the people behind the scenes for their time and efforts to make this program possible. Let's now welcome all of our distinguished physicians and special guests. We thank you for sharing your valuable time, information, and educated insights with us today. Your participation and support help to empower our communities of color, and this is critical to our present and future well-being as a people. Black is beautiful and knowledge is power. Welcome again, everyone, to the Black Health Trust Weekly Program. This is our community, and this is our time to take care of our health. Now, grab your coffee or tea, get comfortable and lean in, and please, Dr. Maxey, begin today's program.
Thank you so much, Dr. Stevens. I appreciate you as always, and I also appreciate Dr. Ivan Waltz for being our co-moderator. And I'm very happy that my friend, Mr. Arnie Joseph, has agreed to be the co-producer of this program. And we have exciting, very qualified speakers today. I wanted to make just a brief statement, and we'll discuss this more at the end of the program, are the current guidances. Because we initially started out looking at the issues that would keep us safe from COVID-19, and we have evolved to where in most of our geographic areas of the United States, the acute infections seem to be going down, and guidelines are being relaxed so that you may not have to wear a mask in all situations, but there are still some cautions that we will speak about later. We also know that despite the acute disease, there has been identified what we're calling the long haul syndrome, or the post-acute syndrome that often follows COVID, even if it's subclinical and you don't know you have it. It consists of brain fog. It may consist of some thrombotic things, strokes, myocarditis, issues of renal failure. We don't know what all those issues are, but we're going to explore them in coming programs, and we're going to present much of this information in a symposium in cooperation with State University of New York Downstate Medical Center on June the 25th. So we're going to ask many of you to join us where we have the first international conference on long haul syndrome. And we're gathering that speakers list now and people to present papers, and we'll have a flyer later in the program. But let's get to what we have today. Dr. Neighbor Stevens, if you would give us our statistics, and then let's introduce our producer in the program for today.
Thank you, Dr. Maxey. So our CDC data from May 8th, 2021 is as follows. Our total US cases from the beginning of this episode in our history is now at 32,446,915. Our total new daily cases for yesterday were 43,256. We have lost 577,857 US citizens since the beginning of this epidemic. And our total deaths yesterday were at 815, which was really not significantly different from last week's. Our total vaccine doses as of yesterday, and that's a combination of people who have received just one, if it's a 2-dose course, or one if it's a 1-dose course, are 257 million. So we're making progress. But you will see on the next slide that as far as African Americans are concerned, we are still at the same point. And I apologize for that black bar, but for some reason, the CDC graphics all had that bar yesterday. We're still hovering at that 8.8%. And so we've got significant work to do going forward in protecting ourselves from this virus. And that's the report for today, Dr. Maxey.
Good. So I'd like to briefly introduce Dr. Ivan Waltz, and I'd like him to introduce Dr. Nabret and vice versa, and then let's go to Dr. Joseph and roll the show. Good morning, Dr. Ivan Waltz.
Good morning and good afternoon, Dr. Randall Maxey and Dr. Barbara Nabret-Stevens and my friend, Mr. Arnie Joseph. I know Dr. Maxey says everybody's his friend, but I'm going to steal. So can we put the bios up, please? So not that I need a bio for Dr. Nabret-Stevens, who is a Harvard graduate, Tufts Medical School graduate, super duper pediatrician, someone who worked in the National Health Service Corps, assistant medical director for Tennessee Bureau of Medicaid, director of pediatric education at Meharry Medical College, served as chair of the NMA pediatric section and member of the NMA Board of Trustees, and currently chair of the Council on Medical Legislation. Dr. Nabret-Stevens has been with the Black Health Trust since the beginning. She brings candor and credibility to the Black Health Trust, and we are lucky to be able to serve with her. Dr. Nabret-Stevens.
Thank you, my friend, Dr. Ivan Waltz. Dr. Ivan Waltz is one of those people that it is a pleasure to introduce, because he's a person that's had the opportunity and took the opportunity to serve this nation in all kinds of ways. Dr. Waltz is, as we learned this week, was born in Guyana, but early in his life made his way to the United States and did his undergraduate and graduate education in California, and then somewhere along the line served in our military. After completing that, it's difficult to believe he's packed all this in. But after completing all of this, he has served as a public health official in the DC area and has served as an advisor to 2 presidents of the United States. Dr. Waltz is a psychiatrist by training and currently is founder and CEO of Ivan Waltz Associates. So it's my very great pleasure to present Dr. Ivan Waltz.
Thank you, Dr. Nabret-Stevens. Dr. Maxey, are you going to introduce Mr. Joseph and get things moving with him?
I'll say his name, you read his introduction, but Mr. Arnie Joseph has been a friend of Black Health Trust since the inception. He is a major and senior executive with several Fortune 500 pharma companies. And he has been good enough to assemble a very high level panel of speakers today who are extremely qualified. But we appreciate you, Mr. Joseph. But if you'd read his CV, Dr. Waltz, I'd appreciate it.
I am happy to do that, Dr. Maxey. And let me just say, Mr. Joseph has been with us before, and we are very excited when he comes because, as they say, show me your friends and I'll tell you who you are. Well, Mr. Joseph brings some pretty powerful friends when he comes. He is someone that I'm sure they enjoy spending time with because he has been in senior level leadership in medical publications and planning, medical education, patient education, and pharmaceutical advertising. He chairs the Communications Committee of the U.S. Department of Health and Human Services Office of Minority Regional Health Equity Council, Patient Advocacy. He is president of the American Diabetes Association New York City chapter. He is a member of the Diabetes Wellness Network for the Atlantic Health System. He has just done so much in so many different areas of healthcare, from the Endocrinology Liaison Working Group, Pennsylvania Men's Health Working Group. He's been a keynote speaker on high-risk consumer engagement and health equity at Columbia School of Public Health. Mr. Joseph, if I read the rest of his bio, we would be here until about 6 p.m. It is just exciting to know that this is the caliber of individual that we have as a part of the Black Health Trust. It's very, very exciting. I'm looking forward to learning a lot. Mr. Joseph, thank you so much for coming back and bringing your friends.
It is my pleasure. Thank you for having me. What we're going to do today is we're going to focus on diseases that many of us are not familiar with. And we thought it would be very important because with so much of a focus on COVID, a lot of African Americans and Latina, we often hear that people are not, they're focusing just primarily on COVID. And there are a lot of conditions and diseases that are going unaddressed, and people are showing up in the emergency department with raging disease. So that being said, we have a wonderful panel, starting with Melody Narayan Blackwell. Melody is the founder of the Color of Crohn's and Chronic Illness nonprofit that she started that's focused on increasing the quality of life for minorities that battle IBD and related chronic illnesses. She is the hostess of What the Gut, a show about digestive diseases on the Facebook platform blackdoctor.org. She lives in Washington, D.C. area with her husband and 2 children. Next, we have Dr. Marjorie Borum. Dr. Borum is a professor of medicine and the director of the Division of Gastroenterology and Liver Disease at George Washington University down there in D.C., near you, sir. She went to undergrad at a place called Princeton University. I'll have to look that up. She got her medical degree right up the road from me here at Rutgers Medical School, and her master's in public health and a doctorate in education from the George Washington University. She has been involved with community outreach programs, many research projects, and her interests are extremely wide, including health disparities, medical education, women's health, gastrointestinal and hepatobiliary disorders. And she's edited 4 textbooks, written more than 460 chapters, and 145 peer-reviewed publications. Dr. Marjorie Borum, we are very excited to have you here. Next, please. Kevin Alexander. Dr. Alexander is an advanced heart failure and transplant cardiologist from Stanford University and is a member of their renowned Stanford Amyloidosis Center. He completed his internal medicine residency training at Johns Hopkins and his cardiology fellowship at the Brigham in Massachusetts, Harvard Teaching Hospital. He then finished his advanced fellowship at Stanford. Dr. Alexander's clinical and research interests include cardiac amyloidosis, heart failure, and heart transplantation. He's co-authored many publications, one of which is really the lead that generated the lead for me to call him several years ago or reach out to him. And he's won numerous research awards, including from institutions like the National Institute of Health and the American Heart Association. The next speaker, the Dr. Richard Allen Williams. Dr. Richard Allen Williams is the founder of the Association of Black Cardiologists. He is a cum laude honors graduate of Harvard University. In 1972, he helped to open and inaugurate the new Dr. Martin Luther King Hospital in Watts, where he served as the associate medical director. During his time there, he wrote the grant proposal that garnered $2.75 million from the NIH to institute the King Drew Sickle Cell Center, one of the first in the nation, of which he became the director. Present, Dr. Williams is the clinical professor of medicine at the UCLA School of Medicine, where he has been a faculty member for 46 years. What I don't see on this slide is that he's written several textbooks on cardiovascular disease and racial disparities. Maybe it's on the next slide. He's also the founder of the Minority Health Institute, which focuses on educational programs to teach doctors about cultural competency, diversity, and healthcare disparities. With that being said, I'd love to introduce you all to my friend, Miss Melody, who's going to tell you her patient journey story. And you need to buckle up because Miss Melody is an awesome individual. Melody?
Hi, how are you? Thank you so much for having me here today. I'm extremely honored to be able to tell my story to your community and to your audience. My name is Melody Narayan Blackwell. I am a Crohn's disease patient. And Crohn's disease is an interesting disease. It is one of the two most common diseases under the inflammatory bowel disease structure name. And there are three. There's ulcerative colitis, there's Crohn's disease, and there's indeterminate colitis. I was diagnosed with Crohn's disease in 2018, which I believe I actually had it since I was a child. Around the age of 13 or 14, I started noticing bleeding. I had been battling stomach aches and digestive challenges for probably since I was 7 or 8. And I had gone to NIH and I had gone to several other places to find out. My mother had taken me to find out what was going on. They never could. They would say, oh, she has to eat this or she should eat that. And I didn't eat poorly. My family is from Guyana, like Dr. Waltz, and from the South, from South Carolina. So we had savory foods, but my family being from South America, they were Indian and they ate a lot of vegetables and a lot of things were natural. So I didn't eat poorly, but my mom still would kind of monitor what I was eating. And I went undiagnosed. Around the age of 13 or 14, I started noticing rectal bleeding. And at that time, there weren't really a lot of pediatric gastros, as that was a new specialty that I think it came about in 1990. And there weren't a lot of those. So if you're a child and you had gastro issues, you went to a GI like Dr. Borum or, just at any other normal gastroenterology facility. And we went to a GI, and I just remember being traumatized by the procedure. And it's funny because my mom does not have any memory of this, but I remember getting the procedure for them to check rectally. And it was like a flexible sigmoidoscopy, I think is what it was called. And they inserted this flexible, like 2-foot long tube into my colon while I was awake. And I could feel this the whole time it was there. And I remember like very distinctly, the doctor was like, are you okay? Are you okay? And I'm saying, yeah, I'm okay. And he's like, I'm not talking about you. I'm talking about mom. She's going to pass out. So my mom was in the room with me. And I remember that. And she has no recollection of that. But I was traumatized by that. And I didn't really even want to go back to the doctor after that. And I remember after them doing that procedure, they said, oh, she has internal hemorrhoids, which I had now in my adult years know that there's a very rare chance that a child really does have internal hemorrhoids. Like there's usually more or something else that needs to be investigated when a child is presented with such a diagnosis or the symptom. And after that, I started I would have stomach aches for 20 years plus after that. And I would just manage it through diet, thinking, oh, if I stop eating this, or if I eat more kale, or if I eat more spinach, it'll manage these pains and reduce them. And I would manage it with that, Pepto-Bismol, and Tums. That's just what I did. So for 20 years of stomach aches, I would take those medications, Tums, Pepto-Bismol. I would sleep in a tub because it was cold and I needed the cool to soothe the pains that I would have in my stomach. And there would be times where I would have stomach aches at least 3 or 4 times a week for like 2 or 3 months. And then it would go away once my management of what I was doing kind of got it back into a good place. And then it would subside, and then it would come back again. And I would do my regimen: kale, spinach, Pepto, Tums. Gone. Comes back again: kale, spinach, Pepto, Tums. So it's kind of on this cycle. And in 2013, I gave birth to my son. After I gave birth to my son, things went crazy. I literally had a lip, this lip right here. We could be talking just like this, and it would start to swell all the way down to my chin. And people will get shocked, like there's something going on with you. So after that, I developed this pattern of, okay, now I go to the emergency room. They say, oh, you ate something, you have an allergy. I don't have an allergy. Okay, let's admit her. She has an allergy. Let's give her Benadryl. Hey, you don't have an allergy. We're going to give you steroids. We don't know what's going on with you. Go to a rheumatologist. They do all this testing. Then they plant the seed of lupus. Why? Because I'm a Black woman. So that's just what it has to be. You know, it's going to be lupus because we can't figure out anything else with you. And because it's so abstract and crazy, and you have edema in your feet and now in your knees and now in your face and your limbs, and your arm is getting stuck and you're having arthritis. So they try to throw me into the lupus bucket. And I say, I don't have lupus. There's something else going on with me. And so this is 2013, 2014. I manage it again with diet. And after I go all organic for about a year and a half, you can see the symptoms kind of dissipate, but you can still see some residual swelling. After that, it left for a while, so I didn't have the stomach aches or the issues. But a year later, so 2016, I had a cantaloupe size amount of fluid on my knee, and it locked my knee. And then I started to have swelling in my feet joints. It would go from the left to the right. And so I went to a doctor, and I said, I think I have a flat fracture. And he's doing all these tests. So finally he says, there's not a fracture. I don't know what's going on. I'm sending you for an MRI. He sends me for an MRI, and he says, there's something autoimmune going on with you. This is autoimmune. This is not something with your foot. Your foot is not broken. We're going to have to send you back to a rheumatologist. And I'm like, oh, not again, another rheumatologist that told me I have lupus. And I kind of put that on the shelf for a moment. And I said, okay, I don't want to hear this, but what can I figure out on my own? And around that time, my stomach aches are so consistent. They're at least 3 or 4 times a week. Nothing I'm doing has made it go away. In fact, now I'm having bleeding like all day long. It like from my rectum, it's just bleeding. There's nothing stopping. And then it goes a step further where I now feel like I've had pain where it would hurt to use the bathroom, but now I feel like Edward Scissorhand is literally living in my colon and slicing it every time I use the bathroom. I'm holding onto the walls. I'm sweating profusely, and I'm shaking, trying to just manage whatever I'm going through as I use the bathroom, and putting things off like we do because of income, uncertainty, just housing challenges, and wanting to make sure I'm not putting my family in any kind of imposition. I just shelve it, and I'm dealing with this. And my husband, he sees the bathroom one day. He's like, okay, there's something going on. You thought you cleaned up, but this looks crazy. And I'm really terrified about what could be going on with you, and you're not sharing it. You're up all night. You're not sleeping. We have a baby. It was a lot. And so it moved me to go to a doctor. I went to a doctor, and I told him everything that was going on, from the swelling in my limbs to now there's abscesses that are bursting in my colon, that I'm having rectal bleeding all day long. It's not stopping, that I'm having these headaches, that I feel like I have an infection. My body feels really weird. And like I'm feeling some kind of hot and cold sweating when I use the bathroom. I'm giving him a list. And it took me a while to get to him, 4 months before I actually went to the doctor, of dealing with this. And so I give him this list, and he's like, okay, I'll check. He's like, I don't see anything. And I'm just scratching my head, like, how do you not see anything when I just said I'm bleeding all day? It doesn't make sense to me. And I said, okay, well, he says, I'm going to do these tests and we'll see what happens. And this was a colorectal surgeon. And I leave the appointment, I do the test, the blood work, whatever he's ordered. And about 3 weeks later, I'm driving back to work, but I can't really lift my head up. I literally feel like someone's pounding my head. And I'm driving there, and I get to work, and I start sweating, and then I'm freezing. And you could see like I got chills, my teeth are chattering, and then I'm sweating, I'm hot. And so it kept going on like that. And I said, I don't feel well. And my boss at that time said, no, you don't look well either. You need to go somewhere. And naturally, I was just going to go home and go to sleep. sleep. And a friend called and she's like, hey, what's going on? I said, I don't know what's wrong, but I don't feel so great. I'm just going to go home and go to sleep. I get to, she's like, no, you're not. You don't even sound right. You're going to go to the emergency room. I'm going to call your husband and this and that. So I get to the emergency room. By the time I got there, I could barely walk into the emergency room. Like I'm dragging my feet. My head is low. I sit in the chair. I get registered. They have to wheel me back because I can't even really function. I'm losing functionality. And she takes my temperature, it's 102.3. And she's like, okay, we've done, and I have this weird cough too. I've had the cough for probably about 4 weeks. And she takes an x-ray, she's doing all this stuff. She's like, I don't see anything wrong. You know, we're trying to figure it out. I said, can you do a rectal exam? You know, I know this feels weird. It sounds weird, but there's something that's making me think that this is all connected. There's something interconnected going on here. And she does the exam. And she just jumps and she says, oh my gosh, you need to call your physician. There's something really going on with you. I'm going to give you Cipro, but you're bleeding like at every vein. And there's these abscesses. And, you know, so she's seeing this when I went to the doctor 3 weeks ago and he didn't see anything. And she's like, you have to call your physician. And I called him and I said, I never heard from you about my test. And I feel really weird. I think it's all connected. And he proceeds to say, well, I didn't call because we didn't see anything abnormal. And I'm thinking, okay, but if you didn't, you still should have called. It's just a part of the procedure. You know, you take tests, I give you answers because this is communication. This is patient-centered. But I didn't get that. So I'm still believing that this is really connected. And I felt an abscess growing and it felt like, you know, like a golf ball size abscess. And my family member comes to get me. And the next day I wake up, I don't eat. I can't even eat. I'm at a temperature of 103.8. The third day I wake up, I'm at a temperature of 104.3. I feel terrible, awful. I can't function, discombobulated. And he gets me in on Thursday. He goes to do the exam and the abscess bursts right there in the office. And he says, you're right, you do have an infection. I know, I told you. And that is when I go into my first emergency surgery. And that is where we started with getting me to determine what I was really going through. And it took about a few months, but by October 2018, I was diagnosed with Crohn's disease.
Wow. Let me just say, first of all, thank you so much for sharing that. It's a lot. It's a lot, and you lived it. And I think for a lot of us physicians, it's important to listen. It's important to listen to that history. The first answer to every question ever when you're doing rounds in medical school, you always want to get the first question because the right answer is always take a good history. And it's just important for us to hear. So it may have been very hard to say, and Mr. Joseph warned us it was going to be a wild ride. And we just thank you for sharing that. And we just feel bad that you had to go through it, but thank you.
Dr. Waltz, let me ask a question of our speaker through you. And the reason I'm doing this, I'm at least mildly upset that a patient does not get communicated with by professionals and physicians when they clearly have an issue. Now, is this cultural? Is it professional? Is it a mixture? Why are our doctors not talking to, listening to, and communicating with patients about significant issues?
Dr. Maxey, I think you actually gave the answer as part of your question, because the answer is yes. You asked, is it cultural? It's all of those things. And one little quick bit, a lot of us go to medical school because people tell us that we're really, really smart, and they lock us away in college for 4 years, and they lock us away in medical school for 4 years, then they lock us away in residency, and then they say, go see people. And a lot of the personalities, a lot of the caring that we may have had at the beginning, that doesn't get exercised as often. And I'm thinking about Dr. Williams and all the work he's done on cultural appropriateness. I'll use that one this time. It's very hard sometimes to get doctors to listen. And I think it's wrong. I think that stories like the one we just heard tell us how important it is to listen. And not just to listen, but don't send somebody home with I didn't find anything. when someone comes to you and they have a significant level of discomfort, I didn't find anything is never the answer you send someone home with. I just think it's wrong.
Absolutely, Dr. Walks. And I will say, you know, I gave you all the abbreviated version, but I have had fistula, about 8. I have had a rectal vaginal fistula. I have had a lot of trials with getting to diagnosis, but it's also made me a much stronger person. You know, I lost my hair, I lost my mobility. At one point, I was taking 4 baths a day. I had urgency. I could not eat without it flying right through me like a straw. And I went through that with being a mother. So there's another layer of this because I still had to make sure that I was present for my child, but also teaching him how to care for someone. And it didn't make me unable. You know, this disability did not make me unable to be his mother. So there's a lot of layers to this, but everyone does not have the capacity to manage disease the way that I did. And that's what propelled me to move forward with Color of Crohn's and chronic illness. Because when I told my story as an entrepreneur, which is the space that I come from, I've owned a business, restaurant, I've owned a property management company, I've owned a bridal shop, an international planning business. So I had that layer of entrepreneurship and people that followed that journey. So when I started to say, hey, I'm going to change this, as Black people, we do shelve our health a lot because we're trying to make sure that we can create a better life for those who are behind us and coming forward. And so I said, watching that from my family who are from another country, and the ones that are here, this is not healthy. This is not the way. You cannot, health is first, then wealth. It's not wealth then health. So I'm going to do the work. And I put my story on the front lines. And that opened up people to start to message me all over once I got the diagnosis. And they were saying things like, I can't find any other Black people with this disease. I thought I was the only one. How do I connect? Can you help me? Can you talk to my aunt, my cousin, my friend? You know, so I said, okay, well, what I'll do is I'll just create a Facebook group. I did not know, I was not aware of how hugely the disparity would be magnified once I got in there. And it was painstakingly so. And I had no choice but to move forward to do my own PSA, to say, hey, if you're dealing with this, eye infection, mouth ulcers, because this is a disease that goes all the way down from the mouth, all the way down the rectal, all the way down to the rectal anal tract. And so people don't understand that. And they're dealing with these extraintestinal manifestations, thinking that something else is going wrong with them, where I had a lot of EIMs. And had I not been as educated as I am as a consumer or as just a person who searches and puts pieces together, I might not have helped or aided in the discovery of what was really going on with me. Because even with the arthritis, there were people that kept saying rheumatoid arthritis. And I said, I don't have rheumatoid arthritis. I have Crohn's induced arthritis. And when you get my Crohn's under control, my arthritis will be under control also.
You know, what is also disturbing, Miss Melody, Narayan Blackwell, is that your communicative ability is so high. That makes me worry about many of us who don't communicate as well. So this is something that we need to bring more to the forefront. If there's any way that the Black Health Trust can help magnify your role, we sure will do that. Dr. Arnie Joseph, do you want to go ahead with our program? And thank you so much. We got to hear more from you.
My pleasure.
First of all, as I shared with you, Melody is a true blessing. Melody, if you could you put the link to your symposium and to your organization in the chat? Because everyone needs to hear from you and everyone needs to know that because of your journey, you formed this organization that's designed to encourage, empower, and educate specifically African Americans that are suffering with this disease, because you found that you felt there was really nothing out there for you. So with that being said, I'd like to now introduce Dr. Marjorie Borum, who is one of the country's top specialists in these diseases and conditions. And Dr. Borum can answer some of the questions that I see in the chat and some of the questions that I've been text about and some of the questions that are posed by Melody. So Dr. Borum, if you could, please.
Sure. Thank you so much for inviting me. I think we do have some slides that are going to be displayed. First, I'd like to thank Dr. Maxey. I'd like to thank Dr. Nathan Stevens, Dr. Waltz, and Mr. Joseph for inviting me and to this very important lecture series that focuses on our community, that focuses on the African American community and communities of color. This is so important that we continue to address these issues in multiple forums because we often do not get the attention that we need about many diseases and in this particular disease in general. I am particularly appreciative to be able to talk about inflammatory bowel disease and talk about a few issues about what we should know, because we don't know it all. We in the medical community do not know everything we should know about this, and we certainly do not know what we should know in people of color. And Melody, thank you again, because your journey tells many of us what we should continue to think about. This journey tells many physicians what they should talk about. And your journey also, while unique, is not uncommon because inflammatory bowel disease is under-recognized in our community. Inflammatory bowel disease is not thought about in our community. There's a delay in diagnosis, there's under-treatment, and because of that, very often there are complications. Next slide. What I'd like to share today, next slide please, is a little bit about the epidemiology, about where it occurs, who it occurs in, what are the manifestations that we have, how we can manage it, and what it means in our community. Next slide, please. When we talk about, next slide, please. When we talk about inflammatory bowel disease, like Melody said, these are chronic, relapsing inflammatory conditions of the GI tract. The two major subtypes are Crohn's disease, like Melody talked about. The other major condition is ulcerative colitis. And the other thing that we talked about, you can have indeterminate colitis, where we don't know which category it falls in. And you can also have microscopic colitis. So let's focus on the two major types, Crohn's disease and ulcerative colitis. Next slide. Historically, Crohn's disease was thought about to be only a disease of whites and only to be a disease primarily of those of Ashkenazi Jewish heritage. What I learned when I came into gastroenterology and when I joined the faculty a couple of decades ago at George Washington University was my practice looked different than other people's practice. While people always talked about whites having inflammatory bowel disease, that's what we were taught in medical school, that's what has been taught for decades, that's not what my practice looked like in Washington, D.C. I had African Americans, I had Latinos, I had Asians, but I had African American, both men and women, who came to me because they were told that their symptoms were, 1, not severe enough, 2, were in their head, 3, it was their fault. Their conditions were related to sexual transmitted diseases because they could not have inflammatory bowel disease because of the color of their skin. They could not have Crohn's disease. They could not have ulcerative colitis. And we all know on this forum, we all know from what we heard from Melody, that this is not the case. And what I did as a young faculty member was to put in a grant to look at inflammatory bowel disease in African Americans. And what I was told was, this is not a group of people worth studying. It doesn't happen in African Americans, and it's not worth studying. And what we know now, and what I have dedicated a lot of my career to, is looking at inflammatory bowel disease in racial and ethnic minorities. And as we have suspected, it occurs in everyone, and it certainly occurs in us. Data has shown that IBD is increasingly recognized, and I think it's important that we know about it and what we should do about it. Next slide. When you look at, next slide, please. When you look at inflammatory bowel disease, it can occur at any age. The peak incidence is in adolescence and in young adulthood, but it also occurs in all ages, and again, after the age of 50 and 80. There's a small difference based on gender, but it can occur at any age in any body. Next slide. Next slide, please. When you look at the genetics of inflammatory bowel disease, while it occurs more often in people of European heritage, while it occurs more often in people of Jewish ancestry, you find that there are others, a non-Jewish ancestry, that can have inflammatory bowel disease. But what is the next most common ethnic group? The next most common ethnic and racial group is in African Americans. African Americans have the highest rate of inflammatory bowel disease, of Crohn's and ulcerative colitis compared to any other ethnic group in the United States. Next slide, please. When you go through the literature, and if you really piece out the literature and look at what's in the journals, you found that hospitalization rates increased in the 1960s, 70s, 80s of African Americans, and in the 1990s with inflammatory bowel disease. Why it continued to be under-recognized is something that only all of us can speculate, but you see that finally it began to be identified in people of color. In the 1990s to the early 2000s, the hospitalization rates continued to increase, not only in African Americans, but in Asians and in Latinos. And in the early 2000s, the hospitalization rates of African Americans for inflammatory bowel disease was greater than in whites. Next slide. When you think about the potential mechanisms, we, of course, are not certain why it occurs. There's an intersection between the environment and genetic susceptibility. There is a balance in the immune system, all of which we are not quite certain about, but we do know that it is not a person's fault that they have inflammatory bowel disease. It is not a person's fault that they have abdominal pain, that they have diarrhea, that they have blood in their stool, that they have perineal disease. It is not something that people can be blamed about, but when I looked at my early practice, very often African Americans were blamed about having symptoms that people did not recognize with inflammatory bowel disease, and that has got to stop. We have got to recognize and appreciate that this is a condition that occurs in everyone and occurs in African Americans and in communities of color. Next slide, please. When we talk about the two different major subtypes of inflammatory bowel disease, we talk about ulcerative colitis. Ulcerative colitis, as one, occurs just in the colon. The presentation can be insidious. Slowly we're getting more loose stool. Slowly we're getting more bleeding with our bowel movements. Slowly we have an increasing amount of diarrhea and urgency, need to run to the bathroom. The diagnosis is based primarily upon history, like Dr. Waltz emphasized in the beginning of our talk. History, history, history. But if people are not listening, we will not get the diagnosis. If people don't hear us, we will not get the diagnosis. Only after physicians hear what you're saying will the exam and the appropriate tests be done. Next slide, please. When we look at ulcerative colitis, and it only is confined to the colon, we tend to look at it from a mild, moderate, and severe. And when you look at these pictures, you can see how it can get angrier and angrier the longer it goes on. It can go from just a little bit of inflammation to a lot of inflammation to severe inflammation, bleeding, friability. And with that, and that happens when people, okay, it can happen because of the disease process alone, but if you're not treated, we're not getting control of it. Next slide, please. When we talk about Crohn's, let's go back to what Melody said. Crohn's can occur from the mouth to the anus. It's not just in the colon. It can occur any place in the GI tract, and it can produce abdominal pain. It can produce diarrhea. It can produce bleeding. It can produce complications that include strictures and perianal disease and fistulas. It can produce things that occur outside of the GI tract, as can ulcerative colitis. But again, we must have a history, an exam, an appropriate test to be able to get the diagnosis. Next slide. So when we look at Crohn's disease, only about 20% of it occurs in the colon alone. About 30% occurs in the small bowel alone. And 50%, the rest of it occurs in both the small bowel and colon, but it can occur in the mouth, it can occur in the esophagus, it can occur in the stomach. And it's important to know that that distribution is throughout the GI tract because it therefore produces a wide variety of symptoms that may not be what the textbook always says. Next slide, please. Because some of the extra intestinal manifestations, things that occur outside of the GI tract, are things that Melody shared with us. You can get skin conditions, you can get eye conditions, you can get joint pain, and you can also get conditions in the liver. But let's go to the skin. When you look at the skin, we have two major skin conditions that are associated with inflammatory bowel disease. If you get the purulent kind of conditions like you see on one of these slides, you're going to go to a doctor. But if you get what you see on the pictures, slides where it looks like bruising, you may not think that this has anything to do with your GI tract. But the other thing I want to bring up is that some of these conditions have been described only in people who have lighter skin. It looks different in people of color. You don't get what people describe as a purple nodular skin lesion, erythema nodosum. You don't get that in people of color. It looks differently. And I can only tell you how many people have come to me because they have these brown or bruising or these painful nodules that nobody knows what it is. And in fact, this is related to their Crohn's disease. And when you look at the eye conditions, this is not pink eye. It is not something that we can ignore because when you have this kind of inflammatory activity in your eye, you can get changes in the back of your eye that can ultimately alter and impair your vision. So it's not just that we have GI issues that need to be taken care of. We have conditions outside of the GI tract on your skin, in your eyes, and you have joint pain. And as was mentioned, sometimes in order to get these other conditions under control, you have to treat the GI tract. If the GI tract is not controlled, then we are not going to get control of these other extraintestinal manifestations. Next slide, please. So when you look at ulcerative colitis and Crohn's, you see that in African Americans and in Blacks, Crohn's happens more often than ulcerative colitis, which is exactly what happens in whites and people of European heritage. Crohn's happens more often than ulcerative colitis. Some of the recent studies have shown that it may be just the opposite in people who are Latino, where ulcerative colitis may occur more often than Crohn's. But I say that just to emphasize that we don't have all the data we need. We don't have all the data to be able to demonstrate exactly what is going on in communities of color. Next slide, please. What we do know is that it runs in families. Twin studies show that genetic factors may be important. Crohn's runs in families. Ulcerative colitis runs in families. People who have a family history may have their diagnosis earlier than people who don't have a family history. But one of the things that is important to remember is just because your mother may have it doesn't mean that you may have it. It's your cousins, it's your aunts. And I can't tell you that very often when people go to family reunions, that's when they realize they're not the only one that has this condition. Their cousin has this condition, but who talks about their bowel movements? Who talks about bleeding when they have a bowel movement? Who talks about diarrhea? It can run in families, and it's not always talked about. Next slide, please. So in African Americans, ulcerative colitis occurs more often in those who have family histories. Crohn's disease occurs more often in those with family histories, but it doesn't occur as frequently. The prevalence of family history isn't the same as it is in white. Next slide, please. What we do know when we look at ulcerative colitis in African Americans and in our Black community, we know that there's no difference in the extent of disease. There may be more reported distal disease, but there's no difference in the extent of disease. Therefore, there should be no difference in the timing of diagnosis. Because there's no difference in the extent of disease, there should not be a difference in the treatment. But in fact, we often are not treated as aggressively as others. Because there's no difference in the extent of the disease, there should not be a difference in the frequency at which surgical intervention occurs, even when it's needed, but we often don't get treated as aggressively, and surgery is not offered even when we need it. And it is so important that we recognize this, because both ulcerative colitis and Crohn's disease is associated with an increased cancer risk. Next slide. When we look at Crohn's disease, it appears that African Americans may have more colonic disease, may have more disease of the ileocolonic manifestations of both. But remember, there isn't a lot of work and a lot of research, or enough research, on ulcerative colitis and Crohn's in African Americans and the communities of color. There have been reports that the disease may be more aggressive. There has been reports that there may be a higher prevalence of certain complications, but there is no difference in the age of onset, in the severity of disease, and in the need for surgery. There's no difference in the frequency of flares or the duration of symptoms, but nevertheless, we very often are diagnosed not as quickly, and we're not treated as aggressively. Next slide, please. Some of the studies, though, have suggested that there may be a higher prevalence of arthritis. There may be a higher prevalence of uveitis, which is an eye condition, but there's no difference in certain skin conditions and in certain kinds of back pain. Next slide, please. What I want to emphasize today is that it's important that we all are listened to when we have our symptoms, because there is treatment available. There is treatment that is evolving, and there is good treatment that is there to help manage this condition and put it into remission. We have a whole spectrum of choices that have evolved since I've been in practice, and all of these are available to people with inflammatory bowel disease, but unfortunately, we're not always treated with the medications that are out there that can work optimally in managing severe disease. There are aminosalicylates, which are a certain kind of medications that can decrease inflammation. We have steroids that can decrease flares. There are antibiotics that should be offered. Nutrition cannot be ignored. There are immunosuppressants that have been available for years. And right now we have newer medications that are biologics that can help with severe disease that is unresponsive to other therapies. But there are now studies that show that biologics are not offered as frequently to people of color. We must advocate for ourselves. We must get doctors to listen to us, and we must have doctors that care. Next slide, please. So when we look at inflammatory bowel disease in African Americans, it's often not recognized. There's often a delay in diagnosis. The treatment should be the same, but that does not always occur. There is no significant difference in the treatment of mild to moderate disease based on ethnicity. And so we all have to make sure that we get the treatment we need. However, the newest medications, the biologics for more severe disease, is less often offered to communities of color. We must recognize what our options are, and we must ask for what we need. There is a higher reoperation rate in surgery because of the disease, and whether that is because we're getting diagnosed later and have more complications, it's uncertain, but it's important that we get the intervention that is necessary. Next slide. So when we talk about inflammatory bowel disease, and we talk about what we should know, we need to know that ulcerative colitis and Crohn's disease occurs in everyone. It occurs in all communities. It occurs in men and women, and it occurs in African Americans and communities of color. We need to know of the symptoms. Abdominal pain needs to be evaluated. Recurrent abdominal pain needs to be assessed. It doesn't just happen because of intestinal spasm. We need to recognize that this is a part of ulcerative colitis, part of Crohn's, part of inflammatory bowel disease. We need to pay attention to that pain, and we need our healthcare providers to pay attention to that pain. We need to pay attention to the change in bowel habits. Blood in the stool is not normal. Treatment is available, and there may be racial variations in presentation. More studies are needed. We are underrepresented in clinical trials. We need to make sure that our doctors listen to us, that our healthcare providers are there for us. It doesn't matter how much a doctor knows unless we know that they care. And so I want to make sure that those of us in the community reach out to our family, our friends, our community, and let them know that if they have any of these symptoms, they should be evaluated for inflammatory bowel disease. Thank you.
Dr. Borum, I want to interrupt just a minute to celebrate your talk. I find myself getting a bit emotional. There's a topic we have coming up on a future program called Death in Custody. And we as African Americans are in custody of the United States, and they are being committed crimes of omission and commission. And a lot that you talked about with the medical profession not knowing or not caring how to take care of our patients, we're suffering as much from the George Floyd, where it's an act of commission. Here, you pointed out all the acts of omission of the major medical community not knowing what to do. And I salute you for that. We have questions for you. Dr. Nabert, are there questions in the chat? Do you want to start the question of this wonderful talk?
We don't have any questions in the chat yet, but I want to, actually, this question is really directed at both of our speakers, because I'm a firm believer in patient-centered care. And I believe that there is the responsibility that Dr. Borum just spoke to in terms of a knowledgeable, caring physician being involved in your care. I also feel very strongly that we have got to stop being timid in demanding. Dr. Borum, you used the term ask. I would say demand that the physician attend to our needs. And if they do not, we have to, if they cannot and do not, then we need to look at finding somebody else, which I'm sure Dr. Maxey is going to come back to in a little bit with second opinion. But I'd like to ask from both of you your position on what should the patient, not that they have all the responsibility, but they are there. What should they do in that office when they have come in with their problem and they do not feel that their problem has been adequately addressed? So I'd like to hear what the clinician's responsibility should be. Dr. Boehm has hinted at it before, and I'd like to hear from the patient and from an experienced patient what the patient should do going forward in that situation.
Melody, why don't you start? Tell us your
Thank
experience.
you. So it's important for our communities first to be seen and to be heard. And that's where these cultural and linguistic trainings come in that a lot of doctors are not adept on. And that is a huge disservice to the patient. But there's also this layer because of health literacy understandings and lack of education for our community from us and for us, that they don't feel qualified to argue or to stand up for themselves. And that's where there has to be a veil there has to be a removal of the veil of inferiority versus superiority. We are not inferior and they are not superior. And what we do as coaches is we give them coaching sheets, things that I've written out to tell them the questions to ask. If they don't feel like they've received an adequate response, then they need to say, okay, this is not the response I need. I don't understand. I need you to speak to me in terms that I can relate to, because that doesn't, if I do not get the education I need about what you're telling me, then I'm not properly being diagnosed. Because if I don't understand what's occurring with me, then I'm not under any space to be able to manage or demand the care that I need. And that's where there's a huge disconnect. People have to go in feeling confident, and a lot of times they don't. So they'll come back to us and we'll talk them through. But as a patient, for me, I wrote down everything that I was not okay with about my physician. I'm not okay with this. Can you change this? I'm not okay with your staff responding to me this way. Can this be changed? If it can't, then you need to change. You're fired. That's it for me. I have the control over my care. You don't. And when people don't feel equipped, though, I constantly remind myself and I speak to our team, but when they're like, well, why didn't they do this or why didn't they do that? Everyone isn't you. They don't come in with the understanding that you have. They don't come in with the education on the disease that you have. They're coming in blind in so many ways. And there's still just the foundation really of structural racism that we go in already not feeling confident with our healthcare provider. So there's that too. Like I go in not feeling confident, knowing that you're not going to properly treat me. Then you don't properly treat me. Then I don't feel strong enough to say, this is not okay. Then I stay under your thumb, and it just keeps getting worse for me and not for the physician, because they're not being taught that they're doing the wrong thing and we're not getting what we need. So we just keep spiraling down until someone says, hey, let me pick you up out of here. What's going on? Let's talk about this. Let's get you out of that space. So we have to have more conversations like this that are community conversations, that are conversations that push and propel upward mobility, but that make us feel more compelled to deal with healthcare. To be honest, we don't want to deal with it. It takes one doctor to piss us off and to not respond the way we think we need them to respond to, and we've closed ourselves off from healthcare completely. So at Coachy, because I was seeing this with people that had ignored symptoms, I've had people tell me, yeah, I went to a doctor in this month. I haven't been back to the doctor in 7 months, but they did tell me I have Crohn's disease and I'm not on medicine. And I have been having stomach aches. So I'm just going to take Pepto-Bismol and Tums. So I have to reset them like, no, okay, I completely understand. And I affirm people where they are because I do understand where they are. And one of the first things that people will normally hear is, well, you can't do that. That's not right. No, you don't say that to someone that you're trying to shift. You have to give them the space to know that I see you, I hear you, I understand your response, but that is not going to shift. Do we want to shift or we want to stay where we are? Because if you want to stay where you are, I'm going to support you too, because I can't move you, but I want better for you. And here's what I would want. And that's how I help with our community to shift them into a space of they trust me. And then because of my response and their trust for me, they're able to invest more in themselves and get to the physicians that they need to get to. And we do different things like through a program called Meet the Medic, where we bring in physicians to come and meet and talk to our community. And that moves that veil and it brings them up to feeling seen and heard. And it allows the provider to talk to patients so that they meet in the middle. We've even had patients shift doctors because of our Meet the Medic program.
That's great. Dr. Bora?
I think I can only applaud Melody for what she is doing and what she has just said. I think it is absolutely critical that you feel heard when you're in a clinician's office. You must find someone that is willing to listen, is not willing to dismiss your symptoms, and is willing to walk your journey. You can't just toss a symptom away of abdominal pain, and we all have it, when it's recurrent, when it's severe, and when it's associated, particularly if it's associated with other things. And I continue to tell the people that I work with, I continue to tell the physicians that I train, I continue to tell the medical students that a person does not care how much you know until they know that you care. You must have a physician that cares, that listens, and is willing to find the answer. If you don't get the answer you want, you have to have a physician that is going to work with you to try to find it. And so I can only re-emphasize what Melody has mentioned. I see in the chat that people have asked about medical facilities working on evidence-based practices when related to inflammatory bowel disease, and there is evidence there. It's just that we have to change the teaching and continue to enlighten those around us and those in the medical field that inflammatory bowel disease occurs in everybody. There is evidence out there. There is evidence that a physician can find out about. And when we advocate, we will make sure that they go and treat us the way we need to get treated and get the medications that we need. I also see in the chat about HMO settings. And in fact, the HMO settings are certainly a different kind of organizational and institutional challenge when it comes to getting health care, but it is not something that is insurmountable, because once you get your primary care physician to get you to a specialist, there is more than 10 minutes that they have to listen to you. And you use every single minute that is available to you in your primary care physician's office and in the specialist office, because they are there and they need to listen and they're there to treat.
Well, thank you so much. This has been so exciting so far. I'm looking for more. Mr. Joseph?
Yes, sir. I am here.
I think we need to go to our next speaker so we can continue this wonderful panel that you have.
Thank you. Next up is Dr. Kevin Alexander, who's on the amyloidosis team at Stanford University. And Dr. Kevin Alexander will discuss a disease that the overwhelming majority of us have never heard of, but like like the last two diseases and conditions we just heard about in the inflammatory bowel spectrum, this is a disease that is extremely important, unfortunately, in the African-American community. So Dr. Kevin Alexander, please.
Great. Good afternoon, everyone. I really appreciate the opportunity from the Black Health Trust and everyone on the panel for the opportunity to speak to you about this disease today, and also to work together with Dr. Williams to talk about this important disease area and its implications for the Black community. So I have some slides for this if they could be uploaded. Okay, so the title of my talk is Hiding in Plain Sight: Hereditary Transthyretin Amyloidosis in the Black Community. Next slide. These are my disclosures. Next slide. So yeah, I'm not sure why these slides are black. They're it's flipped. So it should have been, I guess, white background with black lettering. So I'm not quite sure why they're inverted like this. So I apologize for hard to read this, but this first part is a patient story. And this is just to give an example of a type of case that I saw not too infrequently during my medical residency training at Johns Hopkins. And go back, please. Yeah. So this is a 62-year-old gentleman from Jamaica, and he presented with progressive shortness of breath and leg swelling. And much like the story that we heard from Miss Narayan Blackwell, he had a very long history of these symptoms, went to many doctors who tried different things but didn't really come up with a diagnosis. And ultimately, he was diagnosed with congestive heart failure. And what they noticed on his imaging was that his heart muscle was thickened. And because of, I think because of his race, he was suspected to have this heart thickening due to chronic high blood pressure. But in fact, he really never had a long-standing history of uncontrolled hypertension. And so he ultimately was kind of labeled with this diagnosis, even though it didn't quite fit. And when he was treated with the standard medications that we typically use for congestive heart failure, he actually got worse and was in and out of the hospital numerous times. And I ultimately got to meet him during one of those subsequent hospitalizations. Next slide. So, after, when our team evaluated him, we took a step back and said, what are we missing? Based on the diagnosis that he had, the treatments that he had been on should have had a positive effect. And so I think that this is similar to what we heard with the IBD story. It's always important as physicians to not stop when things are getting worse or things don't quite make sense, to really take a step back and take a broader lens to figure out what is happening. And so in this case, what we decided to pursue was a biopsy of the heart, where we could actually look at a piece of the heart tissue to try to get a better understanding of what was going on. And so these are a couple of representative images. On the left is what the heart tissue should look like. You see a lot of dark pink areas with maybe a little bit of light pink in between them. And those dark pink areas are the heart muscle cells themselves. What our patient had was more of what you see on the right side. And that's, you see the dark pink cells, but in between there's a lot of light purple, light pink material. And so that's abnormal. It's surrounding these cells. It's really encasing all the cells. And so further analysis, next slide, showed that this material surrounding these heart cells is called amyloidosis. And the particular type of amyloidosis this patient ended up having is called hereditary transthyretin amyloidosis, which we'll talk more about. And, at the time we got this diagnosis, but the patient unfortunately had very advanced disease. And also the time of my training, we didn't have treatments for this. And so a lot of what was done subsequently was really to try to control symptoms as much as possible, but he continued to fortunately decline. Next slide, please. So we're going to talk about what is amyloidosis in general. So amyloidosis refers to a family of diseases characterized by protein misfolding. There's dozens of proteins that have been described to do this, that can break down and form these large, rigid amyloid fibrils that can build up in different parts of the body, virtually any part of the body. There's amyloid diseases that many people are familiar with, such as Alzheimer's disease, where there's amyloid buildup in the brain. But you can also have amyloid buildup in places like the heart, kidneys, and peripheral nerves. I'm going to focus on cardiac amyloid or amyloidosis that affects the heart. Next slide. These are the main types of amyloidosis that affect the heart. The first one that you see is called light chain amyloidosis, and that's caused by a part of an antibody that breaks down and can form amyloid that can deposit in the heart, kidneys, and peripheral nervous system. This is a relatively rare type of amyloidosis, but it can be very devastating and be fatal, and has to be treated with chemotherapy. The more common type of amyloidosis that affects the heart is due to a protein called transthyretin. And when this protein breaks down, it can cause two flavors of disease. The first is when a wild type protein, a transthyretin protein, breaks down. And this is a disease that we find in usually older men, and it predominantly affects the heart, although it can build up in other parts of the body as well. The other type of transthyretin amyloidosis that's important to talk about is a genetic or hereditary form of the disease. And this is caused by individuals being born with a small mutation in the transthyretin protein that predisposes them to this protein breaking down. Now, depending on that specific mutation, this can lead to a variety of disease manifestations, from buildup in the heart to the peripheral nervous system and or the gastrointestinal tract. Next slide, please. So this is just to give you an idea of the many different mutations that have been described for hereditary transthyretin amyloidosis. Some of these mutations, like the ones on the left, can primarily affect the peripheral nerves, whereas one mutations on the right in red can affect mostly the heart, and then a mixture of organs. Next slide. So what are some heart symptoms that patients have when they have cardiac amyloidosis? So gradual buildup of amyloid fibrils in the heart leads to the heart getting stiffer and thicker over time. And that causes the heart to also stretch in the top parts of the heart, the atria. And that can lead to heart rhythm problems, and stiffness of the bottom parts of the heart, the ventricles, can lead to congestive heart failure, which is the increase in pressures in the blood vessels of the body that lead to fluid buildup in the lungs and the legs and other places. So common symptoms patients can have are shortness of breath, leg swelling, lightheadedness, palpitations. And these can be very subtle in the beginning and gradually progress over many months to even years, which can make it challenging to pick up an early manifestations of this. Next slide. So it's also important to note, kind of akin to IBD, that there are places that outside of the heart where you can see amyloidosis, this type of amyloidosis, and actually it can be manifest many years before someone presents with cardiac symptoms. And so these are things to keep an eye out for. And in some of the early places that it can build up are in tendons and ligaments. So things like carpal tunnel syndrome, particularly when it's in both hands, is something a lot of patients with this amyloidosis will have. They can have damage to tendons, such as the bicep tendon, which is a tendon that rarely gets ruptured. But in this type of amyloidosis, about 1 in 3 patients will have this. And you can see that on the right picture there, where the kind of Popeye sign of the arm muscle there is from a tear in the bicep tendon. And things like spinal stenosis can also be early clues of this amyloidosis. So this presents a challenge because these are types of conditions that patient wouldn't normally present to a cardiologist with, right? Maybe a primary care physician or orthopedic surgeon. And so kind of highlights the fact that to really identify this disease early, we need a multidisciplinary and comprehensive approach where people in different specialties are looking out for this condition. Next slide. So how do we diagnose this? Well, there's some early clues that we find on standard heart imaging. So an echocardiogram or ultrasound of the heart can show you things like thickening of the heart muscle, stiffness of the heart, that can be clues that there could be a condition like amyloidosis, but there are other things like high blood pressure can also do this. Cardiac MRIs can give you similar information to ultrasound, but also gets a better look at the heart muscle itself. And you can get signs of there being other material besides the heart muscle being present in the heart. And any suspicious signs of these studies should prompt further testing to confirm whether someone has amyloidosis or not. Next slide. So historically, the way to do that is with a biopsy. So it could be a heart biopsy like the patient I presented had. And what you would see there is presence of amyloidosis on histology. And the type of amyloidosis can be confirmed with further advanced tests. Now, the biopsy, particularly heart biopsy, I think historically has been a challenge in terms of diagnosing this condition out in the community, because it's a procedure that's somewhat invasive, but also not every center has the expertise to perform this procedure. And so I think that's been one historic barrier to diagnosing this. Next slide. In recent years, we've been fortunate to have a non-invasive alternative to biopsy in certain cases, and that's called bone scintigraphy imaging. This is a radiotracer that gets injected through an IV, and it binds to the amyloid in the heart, particularly in people with transthyretin amyloidosis. And so you can see in the image on the right, hit this scan, and if someone has this type of amyloidosis, the heart will light up, like you can see with where the green arrow is pointing. And if we find that, we can avoid the need for a biopsy. And so this is a test that takes a couple hours to do. It's not an invasive procedure, and so it really has made it easier to diagnose patients and avoid the risk of a procedure. Next slide. So I'm just going to briefly go over some epidemiologic data. Dr. Williams is going to go into this in more detail. This type of amyloidosis was thought to be rare, but we realize that it's under-recognized. And as we get more observational studies, it drives home this point. There's data, many observational studies like this one, where when people rigorously looked for this type of amyloidosis in people with congestive heart failure, you get these rates of 12%, 16% of patients in these cohorts that have transthyretin amyloidosis. So you're talking congestive heart failure, which is a disease that affects hundreds of thousands. And then you start to, even 1 in 8 or 1 in 6 of those patients that could potentially have that, this type of cause of heart failure, these are significant numbers of patients. Next slide. We did a study a few years ago to try to better quantify the burden of amyloidosis using death certificate information from the Centers of Disease Control. We looked at the reported amyloidosis mortality rates by race, gender, age, as well as geography. Some of the interesting data, I think, came from the geographic heterogeneity that we saw. So you can see states in red here had higher amyloidosis mortality, reported mortality compared to blue states, say in the South. And so what we found was that the upper Midwest and the Northeast had the highest reported amyloidosis mortality. And so that raises a question of why. A couple of possibilities are there some environmental risk factors that are unique to these particular regions? Or what I propose is more likely is that there's a recognition bias, meaning that in these regions that there's an increased recognition of this disease, because remember, we looked at death certificate information. So in order for amyloidosis to make it onto a death certificate, that physician had to be aware of this disease as a possibility. And so next slide. To confirm that theory, we looked at the specific reported mortality by county. And so what we saw there was an even more striking picture. You take Minnesota here, which already had a high reported mortality, and you look at Rochester, Minnesota, and the counties surrounding that, they had an even higher reported mortality. And we saw that pattern in Boston and several other places. And what all those places have in common were that they all had established amyloidosis centers. So the Mayo Clinic and Boston University are the oldest amyloidosis centers in the country, been around for over half a century. And I think that highlights the fact that if your patients are in these regions where they had clinical expertise to recognize this, the diagnosis rates were much higher. Next slide. Other thing that we saw from this study is when we looked at the reported mortality by race, that African Americans had a much higher reported mortality compared to other races, particularly African American men. And this is likely driven by the burden of hereditary amyloidosis among the Black community. As you recall, there's multiple mutations that can cause hereditary transthyretin amyloidosis. The one pointed in the green arrow to the right, the V122I mutation, is particularly prevalent among the Black community. About 4% of African Americans carry this mutation. So there's over 1 million carriers in this country alone. And that confers an increased risk of this disease. And I think shows that's reflected in the higher reported mortality you see on the graph on the left. Next slide. So, I just want to go briefly back to that geographic data that I showed earlier. So, I showed that African Americans have a higher reported mortality. So one could hypothesize that regions of the country that have higher proportion of African Americans would have higher reported mortality. So, states in the Southeast, for example. And what we saw was the exact opposite. So if you look at places like Mississippi, Alabama, which is where I'm from originally, they actually had the lowest reported mortality rates in the country. And so I think that highlights that not only were places out far from amyloidosis centers are underdiagnosing this, but this disease is particularly underdiagnosed among African Americans. And so it's a disparity within a disparity. Next slide. So why is it important to diagnose this? The patient I presented early at the beginning of this, I said we didn't have treatments at the time. That's changed dramatically in the last 3 years. We went from having 0 therapies to 3 FDA-approved drugs that are effective at preventing new amyloid from forming. These drugs have been approved for the heart failure form of this disease, as well as the neuropathy form of this disease. And there's many trials that are ongoing. And so just like Dr. Borum mentioned, the importance of having good representation of African Americans in clinical trials, that's the same challenge that we face for this disease as well. Next slide. So, I just want to summarize here that ATTR amyloidosis is significantly underdiagnosed among Black individuals. There are therapies that are available now. They work the best for early disease. And so that's why we really need to, as a medical community, push initiatives to increase the awareness of this disease and screening for this disease to have the best outcomes. And so I'll stop right there, and thanks for your attention. Sorry that the slides are inverted. I'm not sure why they came out like this on the master deck.
Well, thank you so much, Dr. Alexander. I have a question. I'll at least start before Dr. Waltz and Dr. Neighbor-Stevens. As you may or may not know, I'm a nephrologist. So I see a lot of diabetic patients, a lot of patients with numbness of their feet and ankles when they come in. And I see patients with carpal tunnel. So my previous thought that this person has complications of diabetics. But as a community doctor, knowing that there can be other more devastating effects, what would I be directed to do with my patients who have peripheral neuropathy, who have carpal tunnel, who may have some proteinuria, some nephropathy? What's the next step when a patient comes to me with those items, or the steps for a patient? How do we get them into your realm?
That's a great question. And, that's the challenge with this field, because oftentimes, because this is a systemic disease, patients can have symptoms that affect a lot of different places. And so, even as individual specialists, we have to step back and try to integrate all the symptoms and signs that patients have. So, I think that for the example that you give of someone with carpal tunnel syndrome, some peripheral neuropathy, and diabetes, I think if they have neuropathy symptoms that are out of proportion to their diabetes, meaning, their A1C isn't that high, their diabetes has been relatively controlled, I think that it is important to look further to make sure that there's not another process going on. So, I think things like genetic testing to look for the TTR variant that I mentioned among African Americans is an important thing. But I'd also have a low threshold to refer to a neurologist who has expertise in amyloid neuropathy. Certainly, if there's any signs of cardiac disease or hypertrophy, I think referring to a cardiologist is reasonable. And now that we have these bone scintigraphy scans, which are non-invasive, it's a relatively straightforward thing to screen patients with this scan and get a thumbs up or thumbs down on whether they have cardiac amyloid or not.
Thank you. Dr. Neighbor-Stevens, Dr. Waltz, are there?
I actually have a question, Dr. Alexander. So many times as we get smarter, as the science moves us along, we know that there is an opportunity to use this to help folks. How do you get this kind of new information? You mentioned that we didn't have therapies, but now we do have therapies. How do you get these into the medical infrastructure so that there isn't, well, this isn't covered, or there is a doctor somewhere who is saying, no, this referral is not appropriate, or we're not going to pay for that additional test. There's so much of this that is us getting smarter as doctors, and so much of this that is a part of the infrastructure, not really making it easy. I hate that word, but not making it readily available for our patients when we think we want to order another test.
Yeah, that's something that I spend a lot of time thinking about, and I guess the short answer is that I don't have a complete answer for that. I mean, I think it's a huge challenge. The two things I would say are one, from the specialist side of things, is that we have to not wait for patients to be referred to us, because I think that people will, I see a lot of amyloidosis patients, but I'd much rather see people that have no symptoms or early symptoms than people that have advanced disease, and I need to see them, evaluate them for transplant. So I think that it does come down, responsibility for us to educate and reach out to primary care physicians, general cardiologists, and not just show slides like I did, but have rigorous protocols. And that's something that we started to do in our system. So if you have a patient that is of a certain age and you have these findings, some of these things can be automated because echocardiographic measurements are something that are usually readily accessible in electronic health records, to start to identify at-risk people and then have a pipeline so that they can reach us. So I think building that network is really important. And then I think kind of the discussion we had earlier with Dr. Borum and about IBD is, I think that patients, we have to empower patients to, if you're not getting the answer, to advocate for your health and to raise the awareness and education among patient communities, particularly, for a disease like this that heavily affects the Black community. We need to go to, churches, other community groups, and, say, if you have these symptoms, you should go, doctors, you're not getting these answers, then this is your next step. So I think kind of working at it from both ways, we'll start to tackle this a little bit.
Great, thank you.
And Dr. Neighbor-Stevens, are there anything in the chat?
Well, I do not see anything in the chat. I did want to pursue, though, the issue of this having such a high incidence in the African American community. This, like many other conditions, are prevalent but unknown. And I think that I'm not sure, but I think that when we talk about addressing health disparities, we focus in on diabetes and heart disease and the big names, but we need to start adding these conditions to the list so that we can raise community awareness of what they should be aware of and attend to as they go about taking care of their health. But I was wondering if, Dr. Alexander, if you know of any community outreach activities that go on around amyloidosis in our community as well as our country, to improve, to heighten the awareness of this condition.
Yeah, that's a great question. I think Dr. Williams can also expound on this more in his talk. I think that there's definitely regional things on the regional level that are being done. In California, we have good patient support groups, Northern California Amyloidosis Patient Support Group, which I'm a part of, where we've been doing a lot of, particularly in the video conference era, more of these Zoom type of educational events that have had good reach. I think at a national level, I think institutions like the Black Health Trust and others, I think, have a great opportunity to use those platforms to get the message out. So, I think that there's still a lot of work that can be done at the national level to have a broad-reaching message. And depending on kind of what region you're in, there's, I think, variability in terms of the community outreach.
Yeah. Thank you so much, Dr. Alexander. Before Dr. Arnie Joseph, also known as, is it Moses or Abraham? Before he introduces our next speaker, I'd like to take a point of personal privilege. When we read the statistics at the beginning of the program, and we say that we've lost 500,000 plus lives. All of these lives represent souls. All of them represent people that are loved by someone. They're in our families. They're people that we know. I want to make sure that we keep sight of that. And before Dr. Williams speaks, many of us a few years ago had the privilege to meet a young but very special lady who was able to donate, because of her love, money to create scholarships for Black medical students, especially those that wanted to go into the field of cardiology and cardiac surgery. And she represents the ideal of our community, of somebody who's accomplished, somebody who was beautiful of heart and spirit. And I just want to show her picture for a minute as an example, and that's especially important on Mother's Day, and we want to honor her spirit. Her name was Gigi. She was a personal friend, and for those of us in the NMA and the ABC who had the honor of meeting her, she meant so much. And she's one of the souls that is not with us anymore, but we salute her. But Mr. Joseph, would you introduce our next speaker? And thanks to Dr. Alexander, we appreciate you.
Yes, thank you. Dr. Alexander, if you could please put any links to any information that you can think of in the chat, because as you'd mentioned, the hereditary transthyretin amyloidosis is more common than previously thought. And a lot of physicians aren't even aware of a lot of the red flag symptoms, as we call them. So if there's anything you could put in the chat, that would be wonderful and greatly appreciated. I want to thank you very much for your presentation. Let's see. Where do I begin with Dr. Richard Ellie? Oh, I know what he'll like. Et maintenant, je voudrais vous présenter Dr. Richard Allen Williams, who again has done so much for cardiovascular disease in African Americans. He's written many books. He's started the Minority Health Institute. He was influential in putting together the Sickle Cell Center at MLK in Watts, in Watts. So, Doctor, before you go, Dr. Williams, about an hour ago, put information to one of his books in the chat, and the keywords are one of his books. So please take a look at that. And without any further ado, Dr. Richard Allen Williams.
Thank you very much, Arnie. Can everybody hear me well?
Yes, sir.
Yes.
Great. First thing that I want to say is thank you very much, Dr. Maxey, for two things. Number one, for sponsoring and organizing this wonderful program, the Black Health Trust, which has become a staple now on Sundays for people. And we hope that even more people will become involved and engaged with this great program, which explores disease conditions and situations especially relevant to the African American community. This is something that I hope gets more support. It deserves greater support. And I, for one, want to make sure that I put my voice there to give more support. But we need support more than just voice. We need money for this program. And so you know what I'm saying. I'm sure that Dr. Waltz and others will give you more information about how to provide that support. The second thing that I want to do is to thank you very much for giving a profile of my late companion, Gigi, Janita Evangelista Johnson, who, as you mentioned, was a great supporter of cardiology, and particularly medical students who are pursuing careers in cardiology. And when I say support, I mean big time support from the monetary standpoint. And the Association of Black Cardiologists, the American Medical Association, and other organizations, national medical fellowships, have been particularly helped by her largesse and her generosity. One thing that should be known, which is not generally known about Gigi, is that she passed away basically because of this disease that we're discussing today, ATTR cardiac amyloidosis. That was a disease that I helped her through for 10 years of the life that we spent together. And it eventually claimed her life. So I would like to dedicate the remarks that I'm making in her memory. So to go on to other things, before I launch on to my comments in regards to cardiac amyloidosis, I want to say that there are other things that you're going to hear me talk about that relate to that disease. And one of them I want to bring to your attention up front, because this is Mother's Day. And on Mother's Day, we definitely need, as was mentioned earlier, to consider problems that mothers face, that Black women in particular face. And in the LA Times this morning, I read an article, it was an op-ed by Dr. Karen Scott from San Francisco about how to protect Black maternal health. This is an issue that I'm sure is going to come up on this program, and it has been mentioned in parts before. But on this Mother's Day, I want you to take particular notice of the fact that Black mothers are threatened by death. We need to put greater attention on this. I could give you a lot of statistics, but let's simply say that the United States ranks last overall in regards to among industrialized civilizations or countries with a maternal death rate of over 20% per 20 per 100,000 pregnancies. That is huge. It is something that is embarrassing for a country like ours. I won't say too much more about it. I think that I've given you enough impetus to look further into it. But as Dr. Karen Scott mentioned, we need to end the culture of obstetric racism that has resulted in maternal mortality rate for Black women that is around 3 times what it is for white women. So on this Mother's Day, I want to give you that message before I launch off into my little dissertation on cardiac amyloidosis. Okay. Well, let me simply congratulate Dr. Kevin Alexander for doing the heavy lifting on this disease, which needs particular attention at this time. And I just want to say that it's just remarkable to see the kinds of young people that we are generating in medicine, especially young Black cardiologists. I'm so proud of him and other Black cardiologists who have come along and who have been, I think, stimulated by the Association of Black Cardiologists, which I founded 46 years ago, and which is still going strong and is encouraging people like Dr. Kevin Alexander in their careers. So proud of him, and particularly proud of this presentation that he made today on this very important disease. As he indicated, I'm going to cover some aspects of this disorder, which have to do mostly with the epidemiology, with the demographics, and with other things that might have some more, I guess you might say, comprehensive engagement that people need to know. And I'm going to try to break some things down, especially for those who may not be that familiar with all of the technical issues that we're talking about. So if I could have my first slide. I think there's a previous slide before that. Is that right? It gives my title. Previous to that. Go back one more. So this is the title of my talk. Go back again. Unmasked by the pandemic, cardiac amyloidosis and other racial and ethnic healthcare disparities. The heart of the matter, Dr. Maxey. Remember heart, not kidney. Okay, and we're going to talk about your question regarding your kidney patient in just a minute. Next slide, please. This gives just some of my particular attributes, I guess you might say. And I want to point out in particular that I'm, along with Dr. Maxey, a past president of the National Medical Association, and very proud to be so, because that puts me in a position to be, I guess you might say, a spokesperson for Blacks in medicine. We'll talk more about that later on. So next slide. You can go beyond that picture. That's old anyway.
I would say that's your 5th grade picture.
And I'm giving a disclosure here. I'm a member of the Pfizer Advisory Board on cardiac amyloidosis, as is Dr. Kevin Alexander. And I mention that in particular because that's important. This is one of the groups that is now taking particular attention, giving particular attention to this disease. We're very proud to be a part of that group. Next, please. Well, Dr. Alexander talked about the patients who might have this disease, and I'm just showing a picture of the typical patient with the disease. I'm not going to go into any more detail about that because he's covered quite a bit, except to say that I want to make clear that doctors need to have a very high index of suspicion, no matter what your specialty is. If patients come in with some of the red flags that Dr. Maxey and Dr. Alexander have mentioned, such as the numbness in the feet or the carpal tunnel syndrome history or the spinal stenosis or so forth, they should use that index of suspicion to perhaps order certain things that might turn them on to a diagnosis of this disease. And might I say that even though there may be a concern about coverage of the costs for those procedures, many of them are covered. And that includes some of the genetic testing that one might want to do. And that is very important because as Dr. Alexander indicated, it would be fantastic if one were able to determine that the patient had that particular variant, which is called V122I, which identifies the hereditary cardiomyopathy gene that is present in these patients, especially in Black patients. Next slide, please. Well, this is an overview of what I'm going to talk about, and I'm going to do this actually rather quickly. So this is reaching outside the envelope of the topic that I've been assigned, because I want to make certain that all the dots are connected and that we understand that this is simply a surrogate or one disease that among other conditions, not only diseases, but social situations that we need to consider and have been considered on this wonderful program. I want to mention that the pandemic is a tale of what I call two cities. That means that there's one group of people, let's say whites or Caucasians, who are privileged to lead a certain type of life and get a certain type of an approach for their medical conditions. And then there's another city, which consists primarily of non-whites. And they are affected in a different manner by the pandemic. And speaking of pandemic, of course, we're talking about COVID-19 at this particular time, but I also consider that racism is a pandemic, which underlies all of the things that we're talking about today and that we continue to talk about in these programs. The next thing that you see here is the origins of healthcare disparities. As many of you know, I've written a few books and papers on this topic. And I simply want to mention that the term healthcare disparities is something that actually originated with slavery. It goes back to what Bird and Clayton referred to as the slave health deficit, and that indicates that slaves were exposed to horrible conditions which led to differences in their health outcomes uh, based on the ways that they were treated or not treated. And that led to what we're currently experiencing. Too much to go into right now, but that's something that we're actually moving away from in regards to talking a great deal about healthcare disparities in particular. And I want to encourage you to think outside of the box now to not just individual disease states or clinical situations like we're discussing today, but to patterns that have been established because of the racist history of this country in treating healthcare, and also to the fact that nothing is going to happen unless there are some changes in public health approaches, as well as public policy and health policy, which comes essentially from government. Now, the final thing on this slide in the overview is that there's a common thread running through the murder of George Floyd, things like hypertension, even the treatment of cardiac arrest with CPR. You may wonder about that. Sickle cell anemia and cardiac amyloidosis. And what is that common thread? It's racism. It's too much for us to discuss in great detail today, but I just want to put that in your mind. And you might say, well, what is racism? How do we identify it? The way I always start out in talking about it is racism is like the air and like water. As far as water is concerned, if it's pure water, it's colorless, tasteless, and odorless. And yet it does have an impact on you. So you can't really see it or whatever. And it's also like the air. You may not be able to see it in most cases, unless it's a tornado or a hurricane, but you know it if it hits you. Isn't that right, Barbara Neighbor Stevenson? Uh, at this present time, when you're facing some problems, weather problems, and so forth. So racism is one of those things that kind of sneaks up on you, but if it hits you, and all of us have been impacted by it, you know what it is. Next, please. So I want to give you some definitions which might interest you in regards to the history of healthcare disparities and racism and so forth. And we're going to go all the way back. And you might say, well, what does this have to do with cardiac amyloidosis? It does, and we'll connect the dots in a moment. It's something that was called drapetomania, and that was defined as a slave's obsession with running away. And there was a Dr. Samuel Cartwright in New Orleans who defined that and gave it that term. And his cure for slaves having that obsession was to cut their feet off. That's what he told the owners to do. Well, now slaves who had their feet cut off would still be put to work, but they wouldn't be able to run away very easily. So I just want to bring to your mind some of the horrible things that have happened in our past and why we need to be so concerned with this thing called racism and discrimination, et cetera. Then there's dystopia, where everything is imagined as bad or unpleasant in the entire universe. We sometimes tend to get to that point, and maybe justifiably so. But I think that this is a term that's used more against us rather than by us. We're thought of as being dystopic individuals. Everything about us is bad and unpleasant and so forth. And those people who are white supremacists certainly think about us that way. And there's xenophobia, which is an aversion or hostility towards people of different cultures or races. We've certainly suffered by that. It's been highlighted recently by the hatred, examples of hatred being displayed against Asian Americans. But then to go on to another term, which is chauvinism. And I highlighted the first part of that word, notice that the first part is Chauvin. Remember that Chauvin is the ex-cop who murdered George Floyd. That's defined as asserting or displaying exaggerated patriotism or support for one's own group, sex, or cause, for instance, white supremacy. So you can see how all of this kind of comes into the mix of what I'm talking about. Then there's trypanophobia. How does that factor in? Well, you hear a lot about vaccine hesitancy today, and you wonder why a lot of people are hesitant to take the vaccine that we tell them is good for them. It's not all necessarily because they don't trust the vaccine. They may simply have a fear of needles, injections, or vaccines. 20 to 30% of Americans, according to a study done at the University of Michigan, have trypanophobia. So I throw that out to you just as an item of interest when we're talking about vaccine hesitancy. And I'd already told you about racism, which means different things to different people, like the air and the wind. Next slide, please. So we're moving actually on towards my conclusion, which is going to be on the actual topic that we're talking about. I wanted to hark back to the wonderful presentation that was given last week by Dr. Francis Collins on this program. Absolutely superb. And a lot of what was talked about on that program had to do with genes and the genetic code and so forth. Remember that Dr. Collins was the one who actually defined, along with Craig Venter, the human genome a few years ago. And we've placed a great deal of emphasis on that. And certainly we're referring to that as we talk about cardiac amyloidosis. But in that regard, remember that there are some things that may be more important than the genes that we often herald as causes of specific diseases. And so it's sometimes said that one's zip code, that is where a person lives or resides, or the environment that they're exposed to, may be more important than the genetic code. Remember that, zip code versus genetic code. And so we talk about the relative importance of genes, environment, and the social determinants of health. And so to come further forward from what we talked about regarding healthcare disparities, we need to consider all of these things in the mix now, not just these individual diseases or clinical entities that we often point out to or point to as being afflictions that we are certainly exposed to, but the importance of how all of these things work together against us and why we have to have all of these things in our view, because many of them fly under the radar. Next slide, please. Now, I want to take this bully pulpit to promote something which is obviously a product from me, which is a book that I wrote. Was published recently called Blacks in Medicine. The reason I'm pointing this out on this program is that everything that we're talking about is in this book. It has a subtitle of Clinical, Demographic, and Socioeconomic Correlations. And I want you to read that book because of the fact that you can, in a short period of time, it's a very small book, get a very good picture of many of these conditions that we're describing. For instance, the description of the cardiac amyloidosis that we're talking about, and many other cardiac conditions, as well as even some kidney conditions are in the book, Dr. Maxey, and Dr. Maxey is in the book as one of the outstanding physicians that we need to celebrate. But in any event, the main thing is to read something, if not this book, other publications that reflect on not only the condition that we're talking about right now, but many other conditions that we need to consider in regards to the health of Blacks in the United States. I'm going to finish up by simply mentioning that there are so many other things that we could consider, but I'm going to go back to mentioning that nothing is going to happen unless we look at the importance of having certain health policy in place. And that means that we have to look, for instance, to the Biden administration to do the things that are necessary to address the problems that are being brought up here on the Black Health Trust. I want to refer to an article that was written in the New England Journal of Medicine back last month, April 22nd issue, which had to do with what is called Advancing President Biden's Equity Agenda, Lessons from Disparities Work. I hope that many of you can look at that. I know that many of you aren't going to be able to or won't. So I simply want to mention that what it basically says, that as of January 20th, 2021, the United States has a national policy aimed at addressing systemic racism. And that is the policy that President Biden is carrying out. I mention this because we need to recognize that there is something that has been generated. There is now a bureau, essentially, of health equity, which is very seriously taking its work under consideration. And it's headed by a Black woman who is very dynamic in this. You need to follow what's being done. You need to hold her feet and President Biden's feet to the fire and make sure that they deliver on their promise to level the playing field and make sure that we have the kind of health equity put in place that we deserve and Dr. Maxey is working so hard to achieve through this program. So I know that a lot of what I've said in regards to cardiac amyloidosis is rather a peripheral in my presentation. Like I said, Dr. Alexander gave you the heads up on the condition itself and did the heavy lifting and describing it to you in a way that only he and others can describe. What I want to do is to try to reach outside the box of that individual disease and connect that to all of these conditions that we're talking about on the Black Health Trust and the basic condition that we all must make certain to be energetic to eliminate, and that is systemic racism. Thanks very much for the opportunity to present to you.
Thank you so much, Dr. Williams, and we will be sure to put these in our resource tab. I'd like to thank Mr. Arnie Joseph. And Mr. Joseph, would you like to have a final word before we move towards closure?
Yes, I'd like to thank all of the outstanding presenters for their discussions, and I want to implore that everyone heeds what was recommended and take a look at the chat for the resources that have been listed in there. As we heard, there are a lot of diseases and conditions that a lot of us are not familiar with, but they impact us in disparately high rates. And we need to figure out what we can do to educate ourselves and to self-advocate as well. So I want to thank Melody. I want to thank Dr. Borum. I want to thank Dr. Alexander, and I want to thank Richard Allen Williams for their excellent presentations. And I want to thank all of you for allowing me to guest host. I am humbled by this opportunity. Thank you.
Thank you so much. And I want to echo your giving thanks to our speakers. And I have one question to ask of Dr. Borum. How you get all those degrees after your name and you're still 39 years old? That's I'm so impressed by that. One of the things that has been done in response to our audience with some of the questions raised by both Melody and Dr. Borum and Dr. Williams and Dr. Alexander, that many times we do not have physicians who are culturally sensitive and or culturally competent. And many people are in areas where they don't have Black physicians or primary care physicians or even specialty physicians they can trust. So we, in response to that, put together an answer, and we named it Biometrics Second Opinion Expert. And we have proprietary software that can, with the aid of artificial intelligence that precedes the human intelligence, do a consultation and answer many of the questions that you may have with your care. And we can offer that. There's a website called biometrics.secondopinionexpert.com. And we have physicians that we have vetted. They're culturally sensitive, they're culturally competent. They are mostly African American and other minorities, not totally. And I invite you to submit your medical records and or your questions so that we can help with that. And for those of you who are physicians on the line or health providers on the line, I invite you to go there and be considered to be one of our consultants. We can talk about that later. I know we're well past the hour, but it is important that we protect our community. What Mr. Joseph has been doing, and I salute him, is bringing many of these disease platforms to the table, because the white racists say we're not even qualified to have those diseases, but we do. But by omitting them, we don't get the care that we should. So I thank everybody for being here. Wish everybody a happy Mother's Day. Dr. Neighbor and Dr. Waltz, would you please have a final word before Simon brings up our music?
Well, I'll start off by saying that one comes to Black Health Trust always leaves with a full cup, and my cup is running over. I am angry. I want to continue my efforts in trying to improve the quality of care that are given to our patients. I am empowered because I know I have fellow workers in the vineyard to try to get this mission accomplished. And I am overjoyed that we are able to give our audience the ammunition that they need to help defend themselves as they try to achieve and obtain the kind of care that they really need. So that's where I'm at today.
Well, thank you.
Thank you, Dr. Neighbor Stevens. I feel you, my sister. I'll say that. And let me take my little closing words and say this. So often on days like this, we acknowledge and we celebrate, we pass on Happy Mother's Day, and I want to do exactly the same thing. And at the same time, as we did earlier, I want to honor those who don't have a Happy Mother's Day. Maybe the person that they said Happy Mother's Day to last year isn't here this year. And so I want to just acknowledge that every holiday ain't the same for everybody. And we all acknowledge that we all come from different places and we come with different stories. So to honor what Dr. Williams did, and to all the other folks out there who are looking at this particular Mother's Day with a little bit of a challenge, God bless you and Happy Mother's Day.
Well, thank you. Is Miss Ager on the line? She's probably being celebrated by her multiple grandchildren. So I will say this: Father in heaven, we thank you for your grace and your mercy, and for empowering us to bring these messages and these messengers who are trusted to the table. And we give you all the glory for letting us have this benefit. Amen.
Amen.
Simon?
Goodbye,